Fresh versus frozen embryos transfer, which are better? Early history of freezing human embryos or gametes. 1949, it was first human gamete cryopreservation. At 1984, it was first live pairs with frozen embryo transfer. At 1985, it was first live pairs with SAD blastocyst. And at 1986, it was first live pairs with SAD oocyte. Ovarian stimulation. Controlled ovarian stimulation with exogenous FSH leads to development of large number of mature ovarian follicles. These multiple follicles produce supraphysiological level of estradiol, progesterone, and other hormones. These hormones affect the endometrial development, maturation, and uterine contractile activity. Mature penopods appears 1 or 2 days earlier in the cycle with controlled ovarian stimulation. Penopods function not confirmed up till now. To have the function of penopods not confirmed up till now, but generally speaking, it have a role in endometrial receptivity and implantation. Advanced endometrial histology has been correlated with premature progesterone elevation and implantation failure. Now, fresh versus frozen embryo transfer, which are better? Embryo transfer strategies in IVF. There are two main strategies for embryo transfer during IVF. Either conventional strategy or freeze-all strategy. During a conventional strategy, we transfer one or more fresh embryo during ovarian cycle, in the cycle of stimulation. But in freeze-all strategy, we transfer one or more SAD frozen embryo in cycle other than the cycle of induction. So embryo transfer are disengaged from ovarian stimulation in the ovarian stimulation cycle. This decreases the risk of ovarian hyperstimulation syndrome. As we see, clinical pregnancy rate, implantation rate, and ongoing pregnancy rate are high in frozen transfer compared to fresh transfer. Impaired endometrial receptivity is the main cause of implantation failure in fresh transfer. Why is there need for frozen embryo transfer? As we said before, controlled ovarian stimulation causing supraphysiological level of hormones like estradiol, progesterone, which decrease endometrial receptivity. Also, it increases the risk of ovarian hyperstimulation syndrome. So, when we replace fresh with frozen transfer, we decrease the risk of ovarian hyperstimulation syndrome. Also, we improve the endometrial receptivity. Frozen embryos now account for more than 1/3 of our IVF cycle. This is due to evolution in cryopreservation technique towards vitrification, improvement in stimulation protocol towards antagonist protocol and OHSS-free clinic, inevitable increase in genetic screening towards transfer of single healthy embryo, data on prenatal and obstetric outcome towards safe mother and offspring. Frozen embryo transfer for all normal responder. Two studies done by Rock M et al. First study was at 2015 and second study at 2017. The first study showed increased implantation rate, clinical pregnancy rate, and ongoing pregnancy rate in frozen transfer compared to fresh transfer. But the second study showed the difference in implantation rate and ongoing pregnancy rate were observed in high responder group, in which 10 to 15 oocyte was retrieved. As we see from this table, group 1, 4 to 9 retrieved oocyte. Implantation rate and ongoing pregnancy rate were high in frozen transfer, were similar, but in group 2, 10 to 15 oocyte was retrieved. There is a high implantation and ongoing pregnancy rate in frozen transfer. In high responder, clinical pregnancy rate and live birth rate were high in frozen transfer, while in intermediate responder and low responder, clinical pregnancy rate and live birth rate were high in fresh transfer. So freeze-all with frozen embryo transfer is beneficial in high responder. Cochrane review and meta-analysis 1 show there was no clear evidence of difference in live birth rate between frozen transfer and fresh transfer, but large matched cohort study show higher implantation rate and ongoing pregnancy rate in frozen transfer. Now, frozen embryo transfer versus fresh transfer in specific IVF population. In PCOS patient, live birth rate were high in frozen transfer compared to fresh transfer, but in women without PCOS, live birth rate were almost similar in frozen and fresh transfer. In ovulatory women, live birth rate didn't differ significantly between frozen and fresh transfer, but in patients undergoing pre-implantation genetic tests for aneuploidy, live birth rate and ongoing pregnancy rate were high in frozen transfer compared to fresh transfer. Some probable indication for freeze-all embryo cycle: patient with high risk of ovarian hyperstimulation syndrome, patient who are hyper responder, patient with altered endocrine and cardiovascular profile, patient with inadequate uterine cavity during cycle of ovarian stimulation, patient undergoing pre-implantation genetic test for aneuploidy. What is the common protocols used for transfer of frozen embryo? It may be through natural cycle, modified natural cycle, stimulated cycle, or artificial cycle. Natural cycle, in which ovulation occurs naturally. Modified natural cycle, ovulation is triggered by exogenous HCG, not depending on endogenous LH surge. Stimulated cycle, ovulation is induced by using clomiphene citrate, letrozole, or gonadotrophins. Artificial cycle, ovary is suppressed, and so there is lack of ovulation and corpus luteum formation. Exogenous estrogen and progesterone is used for endometrial development and maturation. In clinical practice, the artificial programmed cycle is popular because it involves less monitoring and there is a suitable time for the patient and the doctor for transfer. In frozen embryo transfer cycle, there is inevitable dependence on exogenous progesterone. This is due to lack of ovulation and lack of corpus luteum formation, so there is deficient endogenous progesterone. What is the role of progesterone in the luteal phase? First, it improves endometrial receptivity. Second, it promotes local vasodilation. Progesterone induces secretory endometrial during the luteal phase, so it is very important for improvement of endometrial receptivity. Decreased endometrial receptivity is the main cause of low implantation rate in IVF cycles. Also, it causes local vasodilation and uterine muscle relaxation by inducing nitric oxide synthesis in the decidua. Choosing the right progesterone in luteal phase support, we can use either intramuscular progesterone, micronized vaginal progesterone, oral micronized progesterone, or oral dydrogesterone. Intramuscular progesterone is potent type of progesterone, but it may cause injection site pain and abscess formation. Micronized vaginal progesterone is preferred than oral and intramuscular type, but it may cause some vaginal irritation. Oral micronized progesterone has low bioavailability and may cause some dizziness, drowsiness, and headache. Oral dydrogesterone is potent progesterone type with high bioavailability. Comparison of oral dydrogesterone with intramuscular progesterone and the vaginal progesterone supplement. A total of 180 patients were divided into 3 groups. Group 1, 50 milligram intramuscular progesterone ampoule twice daily. Group B, oral dydrogesterone 20 milligram twice daily. Group C, 400 milligram vaginal progesterone suppository twice daily. Treatment were continued until 12-week gestation. The results show comparable pregnancy rate among the 3 groups. Miscarriage rate were similar among the 3 groups. All the resulting pregnancy were intrauterine. Midrone trial. Midrone trial compare micronized progesterone plus dydrogesterone versus micronized vaginal progesterone alone. Dual therapy versus micronized progesterone show higher live birth rate and low miscarriage rate among dual therapy, but with low birth weight among single and twin pregnancy in dual therapy versus micronized progesterone. So the use of dual therapy for luteal phase support in IVF frozen cycle is more potent than micronized vaginal progesterone alone. Conclusion, impaired endometrial receptivity in fresh embryo transfer cycle after ovarian stimulation apparently accounts the most cause of implantation failure. In high responder, frozen embryo transfer cycle have higher pregnancy rates than fresh transfer cycle. In normal responder, no difference between fresh and frozen transfer regarding implantation rate and ongoing pregnancy rate. Freeze-all strategy decrease the risk of ovarian hyperstimulation syndrome. Clinical pregnancy rates are higher in patients undergoing pre-implantation genetic tests for aneuploidy during frozen embryo transfer compared to fresh transfer. Thank you.